Okay, so we want to do exercise of early ambulation. That's why we get people up as fast as we can. We don't leave people in the bed. If they've had surgery, we want them up. If they can get up and walk that night, we want them walking that night. Okay? Because early ambulation really decreases the risk. Anticoagulant therapy. One of the Joint Commission and National Patient Safety goals has been to decrease the numbers of pulmonary emboli. And one of the things that we do in hospitals now is we put everybody on Lovenox or a comparable anticoagulant when they're in the hospital. If they're on bed rest, they get a Lovenox shot or something comparable once or twice a day. Okay? Because heparin is a little bit more difficult to manage. And Coumadin we know takes about 3 days to work. And so we put them on Lovenox. Okay? And then we do things to improve their respiratory and their cardiovascular status. So what are some things that we do to improve our respiratory and cardiovascular status?
Deep breathing.
What's that now? Coughing and incentive spirometry, and something simple that we do, positioning, okay? So every hour while awake, we have clients have them cough, we have them use their incentive spirometer. What else do we do to improve cardiovascular status? What do we encourage them to do? Fluids, if they're able. Position. Right. Keeping them in an anatomically favorable position for lung expansion. Okay?
Can we
Yes, Sarah.
talk about diet? Is this maybe where cardiac diets would come in, making sure that they're not, would that make a difference?
I don't know in the hospital, but it might over time. How hard is it to get people to change their diets? Wow.
Really?
Yeah. But certainly teaching them about improving cardiovascular status over time has to do with the cardiac diet, has to do with improving nutrition, has to do with lowering which electrolyte? Sodium. Okay. And then if we have someone who's had a pulmonary embolus, they'll probably be on heparin while we're getting them adjusted with their Coumadin. So they'll go home on Coumadin. And how long they stay on Coumadin depends upon why they got the clot in the first place. Okay? So it might be lifetime Coumadin, might be short term. Then we have this little thing called an umbrella filter. This is a pretty cool little thing. If we have someone who, what do you think might be an indication that you've got a clot in your vein, in your leg?
Pain.
Pain. Right. Swelling. Okay. Is there a temperature change? A little bit warm, right? Okay. That area is warm. Do we want to massage it?
No.
No, we do not want to massage it. Do we want to do Homans anymore? No. Homans sign. We don't push back on the foot anymore because you might throw the clot loose. So if we do, what's that? You know what the Homans is?
It's on our clinical sheet.
To do Homans?
Yeah.
What clinical sheet is it on?
Care plan.
Yeah.
You can have them flex if you can have them pull their foot back, and that would give you a positive Homans sign, but the actual test is to press against the foot.
Yeah.
You do not do that. Anybody doing that? No more, never, no more. Okay? You can have the client flex and extend their foot. And if they have pain in their calf, when they flex their foot, that's a positive Homans sign. Good observation.
The Angelita was having us do it.
Well, that's okay. We'll fix that.
It's not the same thing as when they're testing their neuromuscular.
No, it's not the same thing as neuromuscular strength. It's an actual, okay, who's going to be my patient for a minute? I need somebody who's wearing pants so I can show you how to do,
We get the leg angle.
for just a minute on this table. Don't everybody jump up at once. Okay, here's the one.
Give her a hand.
Okay. I'm sorry, this is not going to be comfortable. You lay down right here so everybody can see. All right. Cool. Just for a second, straighten out your legs, okay? Any pain in your calves? Okay, good. With the Homans sign, the way we used to test it was we put one hand here, and we pull back on the foot, We don't do this anymore. Okay, because if she had a blood clot, I could throw her clot, cause it to dislodge. Okay, what we can ask her to do is flex, are you having any pain in your calf? You flex your foot. Okay? But if someone told me they were having pain in their calf, I would not be messing with their calf. I would be calling the doctor, saying, I have a client who has pain in her calf and it's red, and the doctor would be going, okay, let's do an ultrasound. Okay? So, but that, when we used to do home ensign, we used to do this, and it was regularly part of the postpartum assessment, because if someone had clot in their leg, we wanted to know. Well, now we know we might want to know, but we sure don't want to send it free floating, okay? All right, thank you, Melissa.
So what would be the difference?
Sorry, one second, Susan, and then, I'm sorry, go ahead, Hope.
So positive or negative is for pain?
Pain, right, and yes, Susan. Thank you,
So as long
Melissa.
as they weren't having pain, you could say use their footboard to bed or tell them to, and then if they had pain, they would notify you. So it's okay to tell them to go ahead and,
You would ask them, right, you ask them if they're having any pain. Part of your assessment is, are you having any pain in your legs?
but we were saying that movement of their feet and pushing off the,
It's good as long as you don't have pain in your calf and redness and swelling.
because that would be similar to doing the home.
Yes, yeah, humps, yes. So when you're assessing your patient, you're asking if they have any pain anywhere, any pain in your legs. Okay? So we've determined that we have an embolus in the left saphenous. And we don't want it to go anywhere while we're dissolving it. Okay? And we've given our client heparin because we don't want to form any more. So we're going to, but not a whole lot, because we're going to send them to surgery and we're going to put an umbrella filter in. And it sits right at the bottom, right here, just below the kidneys. Okay? And it goes in through the femoral vein, and it sits in there, and it catches. If the clot breaks loose, it's caught in the filter. Blood still goes through, the clot is caught. And if you have a client who's predisposed to lots of thrombosis in their legs, then you can go ahead and install one of those little guys that'll catch the clots.
What
Okay?
happens to them?
They just dissolve eventually, because by then, at some point you got somebody on Coumadin.
Just keeps it from going to.
Keeps it from going to the lungs. Keeps it from dumping into the right side of the heart. Yes, Deborah.
I had a patient that was allergic to anticoagulants, so she had one implanted right here at the vena cava,
Uh-huh.
and it filtered blood clots. But I was curious as to what happened to them. So they just dissolve once
Well,
they're-
if she's allergic to Coumadin too?
She couldn't take any of them.
Gee, I guess the body eventually over time would take care of them, but I really don't know.
I was just curious.
Yeah. Yeah. That would be a good thing to find out.
Yeah.
That's your clinical instructor.
All right.
Anyway, that's a pretty cool little thing. So, here's a question. Tell whether the following statement is true or false. Bradypnea is the most common sign for a possible pulmonary embolism. False. What do you suppose is? Ah, you looked ahead. Hypnea, not bradypnea, is the most common sign for possible pulmonary embolism. Let me tell you something else they'll do. They will sit up in the bed and say, I'm dying. If a client ever sits up and clutches their chest and says they're dying, they're dying. And you act fast. You don't stop to get vital signs. You're pulling the plug out of the wall. And you're saying, I'm here with you. You're getting help. And you're getting the oxygen, and you're getting everything ready.